until the addingness of the immunomodulators, patients did not have a great overall survival rate. But then when we introduced lenalidomide, we started seeing our patients have life expectancies of between 5 and 7 years, which was unheard of at the time prior to these immunomodulators going forward. So I think it's a lot of promising, and it allows patients to have quality of life versus therapy of life.
You're listening to the ONS podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between.
Hello, and welcome to the ONS podcast. I'm your host, Lenise Taylor, oncology clinical specialist at ONS. And today we're talking with Daniel Verina, nurse practitioner for the multiple myeloma program at Mount Sinai Medical Center in New York, about immunomodulators. This episode is part of a series about anti-cancer drug classes, which we'll include a link to in the episode notes. As a reminder, this episode provides free NCPD contact hours. To receive credit, please review the episode notes for any guest disclosures before listening. Following the episode, complete the evaluation linked in the notes. Thanks for joining us today, Daniel.
Oh, thank you, Lenise, and thank you for this opportunity.
Could you give us a brief overview on the history of immunomodulators in the field of oncology and describe the different generations of them?
When I was doing a little more research on this and deep diving, it was quite fascinating. So immunomodulators therapies have transformed the treatment of multiple myeloma from conventional therapies. And interesting enough that immunomodulators initially started actually in Canada and in Europe, actually in the 1960s. They were used as sedative medications and anti-nausea medications for women who were pregnant. But unfortunately, then the discontinuation of the drug was because of fetal toxicities. Then it actually evolved in 1975. The FDA approved it for actually leprosy in compassion use in programs. And then there was a kind of a hiatus in between of what the therapies would be. But then Dr. Bart Barloghi and his team showed efficacy in 1999 for relapse refractory multiple myeloma patients in combination with melphalan and prednisone. It kind of revolutionized the new treatments in myeloma and what we saw when we used to use just traditional chemotherapy. So it has really springboarded a new era in myeloma. And by doing that, so the first generation was thalidomide, which we kind of said earlier about the side effects of it being used for nausea and sedative programs, but that really was what we saw. And then years later, in 2006, a second generation or an analog of thalidomide was developed called lenalidomide. And it was used in combination with other alkylating agents and proteasome inhibitors that we see like bortezomib, carfilzomib, and ixazomib. And it also has many other combinations for doing that. But over the years, then, with all disease states, patients become a little more refractory to even second generation therapies. And a third generation was developed called pomalidomide, which was initially approved in 2013. Again, in the setting of patients who have failed or progressed on lenalidomide or proteasome inhibitor. So it really has quite a long journey early in the 1960s, but moved up to still being used today in 2026.
That's quite the stretch of how they were able to move over the time, but there's a stretch in between those.
Yes. Interesting enough, pomalidomide is actually a combination of lenalidomide and thalidomide joined together.
What are the mechanisms of actions of the immunomodulators?
It is a very distinct mechanism of action. It binds to a protein called cereblon. And usually cereblons help tag specific proteins for degradation by the proteasome inhibitors inside the cell and help cell metabolism, ion transport, and protein quality control. But leading to this target degradation, transcription factors like Icarus and Iolus are the bigger targets, and it allows then for a direct kill or tumor death, or like what we use the word apoptosis in myeloma. It also inhibits angiogenesis, which is the development of circulatory or vessels, blood vessels, And it literally boosts the immune system, so natural killer cells or T cells to attack cancer cells. So that's kind of what they do. But they also have, if we start really breaking it down to each type, it has a direct anti-tumor effect. It induces cell arrest and apoptosis by inhibiting what our key oncogenes would be. It immune system modulates, so it stimulates T cell proliferation and cytokine secretion, like interleukin 2, while activating natural killer cells. So, really boosting our own immune system. But also, even on a microenvironment setting, they inhibits angiogenesis, like I said earlier, and reduces the production of cytokines such as interleukin 6, which are pro inflammatory interleukin chemicals, and TNF alpha in bone marrow disruption to support.
Wow, that's actually multimodal. That's actually pretty cool.
And they're kind of interesting when you start breaking out each generation themselves. They are small molecules, which are common, and they have very similar makeups to each exact generation. But really, what changes was this mild chemical portion called the glutaramide portion, and each one was slightly altered or changed. So it forces the cereblon E3 ligase to degrade proteins in its normal that it wouldn't. Lenalidomide actually was more potent than thalidomide, and it decreases TNF alpha, interleukin 1, interleukin 6, or interleukin 12 production. Again, stopping that pro inflammatory process, which really incites or enhances myeloma cell growth. Even pomalidomide did the same thing. So it kind of is very similar, but each one built one upon the other.
What are some of the biomarker testing that a nurse would anticipate before someone would be prescribed immunomodulators?
So there really isn't a direct one-on-one target when it comes to immunomodulators themselves. But what we do is we'll do some like pre-tests prior to starting therapy. So we'll look at renal function. Immunomodulators are renally dosed, more specifically to lenalidomide, which we'll talk a little bit later about. We definitely want to look at somebody's complete blood count or CBC to make sure that not neutropenic or thrombocytopenia, low white blood cells or low red blood cells or platelets. I always think about this is we definitely want the diagnosis of multiple myeloma before initiating this drug. So we're going to look at serum protein electrophoresis. We want to make sure that we know the patient has serum-free light chains, myeloma proteins to really confirm their disease, plus probably a bone marrow biopsy. But even the biopsies, we do know that it targets, if we use this fluorescence in situ hybridization, or what we may say the word FISH, you might hear, to identify high risk features like deletion 17p, right, which is a suppressor gene, or translocation 414, which are really good targets for these three therapies.
What are some of the most common toxicities and adverse events associated with immunomodulators, and what strategies could be used to prevent or manage them?
Some of them are very common with all three of the generations from thalidomide, lenalidomide, and pomalidomide. So definitely we're going to talk about neutropenia, thrombocytopenia, and anemias. It's very common across the board. Generally, when somebody is initially started on these therapies, you're going to see the patient frequently and monitor CBCs, their complete blood count. So frequent blood testing, which we can do. Dose interruptions or dose reductions might also be part of the management when these side effects occur. And sometimes giving growth factors. So giving somebody a growth factor to boost maybe their white blood cells. Other common events is actually deep vein thrombosis that we see. So venous and arterial thrombotic events are very common with these therapies. So patients should be mandatory on some type of prophylactic anticoagulation. It could be as simple as I call it as an aspirin, usually 81 milligrams for low risk patients. But we may have to increase if they're more sedentary or other high risk characteristics that may occur. We may give them low molecular weight heparin or direct or anticoagulations that are for higher. Sometimes we actually use the anti-10A factors. Myeloma is a very interesting disease. Patients walk in the door being immunocompromised, and infection is one of our criteria if somebody's having multiple infections. But by giving them immunosuppressive therapies, it may increases their risk. So we do see our patients might have more risk for infections like pneumonias. Upper respiratory infections tend to be most common in myeloma. So infections, maybe a urinary tract infection, things like that. We do know that patients can also, it suppresses their immune system. So reactivation of the herpes zosters virus is quite common. So patients should be on some type of antiprophylactic against shingles. And if their immunoglobulin G is very low, generally less than 400 milligrams per deciliter, the ability to start intravenous immunoglobulin therapy can be done. But you also may have to hold the patient's therapy. Rash across the board, we saw a lot of cutaneous reactions or rashes. We saw them more with thalidomide and with lenalidomide, but not as much with pomalidomide. It can be very mild to moderate. Some patients, when they start or initially start the therapy, they get an itchy scalp. It's kind of an immuno response, and we can treat it with some type of either antihistamines or transient holding of the therapy. If it's a skin rash, we may use topical corticosteroids for that patient. Very low on the risk, but I think very missed out side effect is peripheral neuropathy. I'll talk a little bit of a sidebar. So protease inhibitors tend to be more known to cause peripheral neuropathy, but the immunomodulators also can cause peripheral neuropathy associated especially with thalidomide but seen also in lenalidomide and pomalidomide. So again, management might be dose reduction of the therapies themselves or discontinuation if the peripheral neuropathy gets unbearable or becomes effective of the patient's activities alone. It does say it's sometimes irreversible, and it is true, depending on how quickly you catch the side effect and stop it going forward. I always love the word fatigue because I think the whole world is fatigued, but chemotherapy and especially immunotherapies can cause patients generalized fatigue. So, we might do special testing to look at thyroid stimulating hormone, cortisone levels in the patient, maybe educating them not to take very long naps and stay as active as possible. GI tract issues or gastrointestinal issues do occur, and they're quite interesting. I always love the joke when one drug gives diarrhea and constipation. I think it's confused at some point, but we do see more constipation with thalidomide and more diarrhea when it came to lenalidomide and a little bit less with diarrhea with pomalidomide. So again, modifying lifestyles in our patients, giving them proper hydration. I think in the world, nobody drinks enough water, especially if you're a healthcare professional. I don't think we're allowed to drink as much water as we would like to. So you definitely want to enhance proper hydration. Over-the-counter medications like some type of antidiarrheals may help. And those are the major side effects. Other side effects, I think, that we don't really talk about as much, but we need to, is some of these therapies have been causing what we call secondary primary malignancies. And they have seen in patients with long-term use in lenalidomide for maintenance therapy post autologous stem cell transplants. And we see that in approximately 1 to 10% of the patients. And what are these secondary primary malignancies? Again, something as healthcare professionals need to be mindful of is that it could be myelodysplastic syndrome or MDS or acute myeloid leukemia or AML. But we also see them develop acute lymphoblastic leukemia or ALL. From a solid tumor perspective, we do see patients have developed either melanoma, prostate, or lung cancer. So again, always asking those second questions to those patients. Did you see anything change? Are you seeing any new changes in moles and things like that? Like I said really earlier in this discussion, embryo fetal toxicity definitely needs to be addressed with all of these therapies, the 3 immunomodulators that we see, because again, in the 1960s, we did see the fetal toxicities occur. One of the side effects that we saw was actually severe limb abnormalities, and we saw it similar to when the thalidomide. So it is contraindicated to give any of the immunomodulators to women who are pregnant themselves. For females of reproductive potential, they must use 2 reliable forms of contraceptives or avoid heterosexual sex for at least 4 weeks before they initiate the therapy, during therapy, and actually 4 weeks or 28 days after their therapy. And what I always say is always refer back to the prescribing guidelines because a lot of these immunomodulators are in combination with other therapies. So you want to make sure we're always using the correct length of embryo fetal toxicity protection itself. it's important, and something from healthcare professionals that we have to do for females is obtain 2 negative pregnancy tests prior to starting the therapies alone. And then it depends on your institution, but it is required that they have monthly pregnancy tests while they're on these immunomodulators, and all 3 of them alone. Now, for males, it's very unique in itself that lenalidomide actually presents itself on the semen and not the sperm. So men must use condoms during intercourse if their female partner is childbearing potential and during treatment. And again, similar like to females, after 4 weeks of stopping the therapy. So they must keep using the condom itself. And because of these drugs, they are part of a program due to their high risk. So we have to register our patients alone. So we do see them. When we talk about each medication separately, each one has slightly different side effects. So thalidomide's biggest side effect is constipation, weakness, and fatigue, somnolence, and peripheral neuropathy. That numbing and tingling in the fingers or toes, or it may radiate up their legs, and rashes, mood swings, and depression. We do see that in coordination or hand tremors with those. But differently enough, with each generation, less of the side effects actually occurred. So lenalidomide, again, most of their side effects, not discounting the deep vein thrombosis, but was more of the pancytopenias, the neutropenia, the anemia, and the thrombocytopenia, very similar in pomalidomide, keeping it unique for each drug itself, but they do have the same commonalities that we spoke before. That was quite lengthy.
It's quite the laundry list, too.
It is a very long laundry list.
I think it's important because these are really, because they're on these therapies for such a long time. I think sometimes we have to remind ourselves to talk with them when they come in and discuss the things that we don't want to discuss. And I think that the sexual health piece is important. I think we're all, as nurses and healthcare professionals, we're all really focused on fatigue and trying to describe how that fatigue is not the fatigue of staying up until 2 a.m. and how it's different. But describing peripheral neuropathy to somebody who's 30 is really 30, 35, 40 is really difficult because it's not even in their wheelhouse to even think about. So remembering to ask those questions because they're going to think that they're just tripping on something or their shoes were too tight or something like that.
I always describe, myeloma being a more mature adult age disease, age of, diagnosis generally 69. But we are starting to see patients much younger in their 20s and their 30s and their 40s who still may want to be childbearing or have a child or be able to down the line alone. So I totally agree with you that really mentioning it up front, and do they need fertility preservation prior to starting all these therapies alone? And you brought up a really good point, peripheral neuropathy, and it's so unique to each person. Besides numbing and tingling, sometimes patients may describe it as I'm wearing socks when they're wearing bare feet. It's like walking on sand, or I'm wearing bubble wrap on my feet. So it's kind of being able to let them describe what the neuropathy is and not tell them what the neuropathy is.
You talked a lot about those fetal toxicities and contraception and that sort of thing, and those tying into the risk and evaluation and mitigation or REMS programs in relation to these immunomodulators. Can you describe the importance of those and then maybe a little bit about how they tie into prescribing the medication and the patient getting the medication and that sort of thing?
So the risk evaluation and mitigation strategy program is critical for all immunomodulator therapies, thalidomide, lenalidomide, and pomalidomide. And it was developed absolutely due to that high potential risk of developing embryo fetal toxicities. So these drugs, they're actually known as human tetragenergic risks for causing birth defects, such as either fetal death or limb deformities alone. It is mandatory testing and counseling. So all females of reproductive potential must have 2 negative pregnancy tests prior to starting the therapy, and then monthly pregnancy tests while on the therapy alone. Again, they must use 2 forms of, I always say, effective contraceptives, or abstain from heterosexual sex 4 weeks, like we said, 4 weeks prior, during, and 4 weeks after. And the same thing with men. I focus on that because men will say I might have a vasectomy. So these therapies tend to bind to the semen. So they still must use a latex or a synthetic condom during any sexual contact with female of reproductive potential. even if they did have that vasectomy. So it's kind of a challenge to bring that up. And I like to discuss it with everybody across the board and leave it alone itself. From a mandatory respecting that all institutions, so mandatory enrollment in education is thread or a foundation to these REMS programs themselves. They're certified only for certified prescribers can prescribe it. So healthcare professionals must be enrolled to provide these therapies alone, and only certified pharmacies can dispense it. So it's one of my challenges. The patients like, can I just go to my local CVS or Walgreens or the local drugstore down the block? And unfortunately, no, it is limited to specific specialty pharmacies. And usually those specialty pharmacies are also dictated by the patient's insurance alone. So the patient must be educated, enrollment, and sign with the patient and physician in agreement. And you're going to go over all of these tactics. One of the major questions are you want to tell them, make sure that you don't donate blood, that you're not sharing the medication with other patients or other people around you, understanding the agreement, and they sign on to it because every month the patient is going to have a survey to provide that so that they can have the pills or the medications again redispensed to them. So again, no donating blood or sperm, and be able not to share the therapies. One of the things I think when we talked about educating our patients when it comes to the therapies alone, again, is that sometimes I know people love humor, but when it comes to these REMS programs, they're very serious about when they ask specific questions about, are you sexually active? Are you using effective contraceptives? Have you donated sperm, whether it's male or female? And it's important to answer them clearly and truthfully without trying to make a joke or try to make it levy, because it can inhibit the dispense of the drug. The account might be put on hold until those questions can be redefined again.
What key administration and dosing considerations should healthcare professionals keep in mind when caring for patients receiving immunomodulators?
When we think about as healthcare professionals, and definitely registered nurses are at the forefront, really. And then you have your nurse practitioners and your physician assistants as second line in that therapy, is that all these agents are oral agents and they are taken at home. So it's very different. They're not going to come to your institution to have their immunomodulator handed to them. So they're going to be taking it at home. Part of the REMS program, too, is that the patient has to sign for the therapy when it gets mailed to the house. So they can't just leave it on the front porch. It can't be left in their mailbox. So somebody has to actually sign for to say that they received the drug. So we always want to advise them it's a capsule. And generally, because these therapies can make people very somnolent or tired, I advise them to take it at night so that they can rest and sleep at night. The capsule itself cannot be chewed, crushed, or opened. And I bring that up because we as healthcare professionals have educated our patient. If it's difficult to swallow capsules or tablets, we've always said to them, oh, don't worry, just crush it and put it in applesauce, or, open it up and sprinkle it on your mashed potatoes. But because of this fetal embryo toxicity, the neurogenic effects that it can have on females with reproductive potential, again, I advise my patients not to open the capsule. If they can't swallow it for any reason, they have a sore throat, they're just unable to, then to hold the therapy and then call us. That's kind of important. And again, asking that at the bedside and really bringing that up. And then doing those deep dives of the side effects that we talked about earlier, right? Are they seeing easily bruising? Do they feel more fatigue? It could be low red blood cells or anemia. Do they think that their legs are a little bit more swollen, one more than the other? And are they adhering to taking their anticoagulation that's important to prevent deep vein thrombosis, like a baby aspirin, low molecular heparin, or other therapies that are available? And like I think you said earlier, Lenise, really describing peripheral neuropathy, letting them tell us where it is. Can they feel? I always ask, can you feel the difference between hot and cold, like in the shower or water? Can you know where your foot is on the floor? That proprioception, like saying, oh, my foot is here, but really it's in a different spot. So really diving down to them and how it feels to them. Fatigue and exercise, we talked about earlier too, and really managing that. And I do hone down a lot on the embryo fetal toxicities because in our practice, we're starting to see much younger patients alone. So as healthcare professionals, we need to be mindful But leading to that, as healthcare professionals and the APPs, advanced practice providers who are dispensing or writing for these therapies, we also have to be inconsiderate to think about how are they administered and how are we dosing them. Thalidomide really has no renal dosing. So many patients in myeloma come in the door with renal insufficiency. So it's something to be cognizant about. But the second generation lenalidomide is renally excreted or renally dosed. So we have to really look at what is the patient's creatinine clearance. Is it less than 60? Do they have end-stage renal disease? Are they on hemodialysis? There are different schedulings and different dosings for those particular patients and what their renal function is at. And then we look at pomalidomide, actually it doesn't need as much renal adjustment, but until patients are really requiring on dialysis or less than 25% reduction of that. So again, keeping that in mind. But knowing that our patients do take other therapies, excluding what we're giving them in myeloma, we need to also think about pomalidomide is processed a lot through the liver. So we have to think about all the CYPs in any interactions to these therapies. So your healthcare professionals and tagging in there pharmacists, either in your hospital, at the sites themselves, is really talking to them and say, are there any interactions I need to think about before prescribing these therapies? So are there interactions from a liver standpoint? So I think those are important collaborations between all healthcare providers and your pharmacists.
I want to circle back on a couple of things. One of the things that you talked about in the REMS and then also in relation to these toxicities is you have to go through REMS and you have to wait for these medications to be delivered. Is there anything that you have to keep in mind in relation to starting the rest of the regimen while you're waiting for the immunomodulators to arrive?
We tend to, in upfront therapy, so induction therapy in myeloma, I may start them on their upfront therapy in waiting for the lenalidomide to be approved for them. So off kind of as we can use the monoclonal antibodies, we might start them with the proteasome inhibitors in combination with some type of steroid or some type of alkylating agent, such as a cyclophosphamide, until the drug is actually approved, and then switch them out. So we will start their therapies to improve their disease control while waiting.
And then the other thing you talked about was the fact that these are oral medications. They can't be crushed. They can't be dissolved or anything like that. And I know that as a clinical nurse specialist, I would often get a phone call at 5 o'clock on a Friday saying they can't take their meds. Can the pharmacy crush and mix it up for us? If they can't swallow, do we just hold their doses until they can?
Yes, I actually hold their dose and then have the patient actually come in to be evaluated, whether they're being evaluated by their local primary care physician for they may have an infection, a sore throat, some type of oral, maybe thrush or something that's going on, or they'll come to our institution. So being seen by a healthcare professional is important before trying to have them reinitiate the therapy itself. In dispensing the therapy, the patient needs to have monthly blood work done to make sure that they're tolerating the therapy. So they're not having the hematological pancytopenias. They're not having worsening renal insufficiency before we redispense the next month. I always advise patients to call me at least 4 days before their last dose so that we can start the REMS program and get the drug to them on time, because they'll have their blood work done prior for that.
So in that mode with all of these side effects and all the things that they can experience, what strategies can nurses use to support treatment adherence with the immunomodulators?
I think nurses are the forefront of education and always support for our patients alone, explaining the importance of taking the medications as prescribed to achieve the better outcomes. And like we said before, if they can't swallow the therapy for some apparent reason, that would be a reason not to take it, but really telling them to keep on mind daily for 21 days in a row. Reinforce them to tell us if they're having side effects, because being newly diagnosed patients or even getting, I always say, therapy fatigue. Sometimes either A, they're just too scared to take the therapy. They're tired of taking therapy. They're like, why do I have to take it every day? Kind of like when patients stop taking their antibiotics because they feel better. So it's kind of saying you're doing great. So it's why it's working to keep them on that. I think giving them calendars. And I think everybody has many different ways to administer their therapies. You can't put this drug in a pill box because of its embryo-fetal toxicity. So it needs to stay in the medication container that it was delivered in because it's sealed and locked. It needs to be stored away from anybody. So for children or women of reproductive potential, don't handle the therapy. It really should be the patient handling their own medications and not put it in the pill box itself, because somebody might accidentally go into the pill box and take the wrong pill by chance. Letting them know to either use, there's many different apps out there in the world, right? We have digital phones. Everybody has a smartphone. They can set alarms when to take the pill itself. Sometimes people don't like that. So I say, write it on a calendar. Sometimes I provide them the calendar and say, these are the days you're going to take the therapy on. And here's the 7 days that you're going to hold it. And I say, bring me the calendar and see the check marks when they took the therapy itself, or keep your own calendar. So writing it on a calendar, using your phone or other applications. And you know who's really the best person too sometimes is the care partner, who can help remind the patient that, did they take their therapy today? Are they on time? Are they also managing their symptoms? Do you feel well? Any of the symptoms that they talked about, do you have any of those? So I think those are the best strategies out there.
Excellent strategies. And I love trying to find a way that a calendar will work for the way the person works, as opposed to saying, write everything down when you've got somebody who's not somebody who writes something down, but there's somebody who uses an app. So being open to explore different options for people who work differently.
Absolutely. I mean, everybody, some people use spreadsheets better. Some people, you're right, writing it down, spreadsheets, or having the phone tell you.
Yep, exactly. I think to follow along with that, what are some primary patient education points to communicate to patients and caregivers about immunomodulators?
I think it kind of ties back to saying the importance of monitoring them themselves. Be mindful of what they're doing. So taking it on time, making sure they're taking it more in the evening because it makes them, it's somnolence and makes people feel sleepy. So it might give them better rest because they're on steroids, which can make people have insomnia. Monitoring side effects. Do they see changes? Do they see more swelling in their lower extremities? Are they developing a rash? And that's where the care partner comes in, because I don't think everybody can see their backs. Generally, I can't see the back of my head. So you're not going to really see rash on your back of your skin. So really asking them to keep an eye on you. Care partners are important too, because the patient may not know, like you mentioned earlier, like they're tripping without knowing they're really tripping. And they think it's the unevenness of the floor. And the care partner would be like, no, this is different because they never really tripped as much as they do now, or they're holding onto the walls when they walk a little bit because they feel a little more unsteady. So really, really empowering. I always say it's really empowering the patient in the decision and in the process, but also bringing the care partner involved in that when it comes to that. I think the nurse re-educating, there are many, many resources out there, from the International Myeloma Foundation, the Multiple Myeloma Research Foundation, that really provide other reading materials for patients to remind them of the education of how to take the drug. Take their temperature. To say, I just felt warm, I don't have a fever, really take your temperature, right? Know what the fever is and really tell us going forward. So those are really good tactics of how we educate our patients to monitor these.
Yeah, give them very tangible things to look for.
Because I'm very tactile. So yes, tangible, I have to know. It has to be in front of me.
Okay, we talked about managing adverse events and toxicities. How can healthcare professionals from different disciplines collaborate to manage these adverse events and toxicities and provide patient education and serve as a trusted source of information?
You always say a village, it takes a village to care for a cancer patient, and it's absolutely true, but you're also taking care of the care partner. You're going to have your primary team. You're going to have your hematologist. You're going to have your healthcare professionals, whether it's a nurse practitioner, registered nurse, a physician assistant, very involved in the patient's care. You're going to have your medical assistants who might even talk to them and be like part of the team and say, oh, they told me they had a cold, when they don't tell the healthcare professionals that they actually have a cold. Really integrating your pharmacists, your PharmDs involved, and then making phone calls to check up on them and saying, How are you tolerating it? Are you taking it right? Are there any symptoms? And in the REMS program, they do that. They do reach out to the patients and they do ask them survey questions to see how they're feeling and if they're tolerating the therapy well. Then adding more specialties to the patient's team. So if they start to develop peripheral neuropathy, whether we dose reduce the therapy, whether we hold the therapy, sometimes getting a neurologist involved might also help decrease or find other medications that might help decrease the symptoms, make it more manageable for patients. If they develop deep vein thrombosis, we have to send them to a cardiovascular or peripheral vascular specialists alone. So really keeping everybody involved, but also integrating in there is the care partner. What support do they need to continue the care of the patient? Because they've had those advertisements and it's not just the patient who has the disease or the multiple myeloma. They'll always say like, she has myeloma or he has prostate cancer. Or I've heard very good commercials where they've said, she has prostate cancer, he has breast cancer, saying that they are also experiencing some of the stressors.
That is so true. It's the entire family who has the diagnosis. It's just one person who's having to deal with the treatment in their body themselves, but everybody else in the family is impacted by it or in the partnerships.
You have to support the entire nucleus around the patient and their support groups.
Well, this has been pretty fascinating. What do you think the future looks like for these agents and their role in the landscape of cancer care?
I thought about this question and I really kind of put my mind to it and said, the immunomodulators are still currently the foundation of the therapy of multiple myeloma. We do have newer therapies coming out, like these T-cell engagers or even CAR T, which is moving up further into the front line of our patients' therapy. But they do play a role up front. If patients do relapse, will be there. We spoke about 3 generations already, but there's actually a 4th generation. They're called cell mods. It's another generation or the 4th generation of the immunomodulators still in clinical trials, really showing promise in the therapy of myeloma. So one was called mezigdomab and the other was called ibrinamide. And they're really showing very good affinity to cereblons, just like the immunomodulators do. So it still will be part of what we do. I think in all cancers, I think in all therapies, as newer generations come out or newer therapies move forward, some of the older generations might move aside, but they get integrated later on. So I don't think they're going to disappear totally, but they will be probably modified.
Daniel, has been great talking with you again. I have just a few more questions for you. How might healthcare professionals' hidden or implicit biases impact their care of patients receiving immunomodulators?
I think everybody in healthcare professionals come in with a certain focus. And it comes from, I think, what they've read in literature, but also what maybe they've seen in experience. And I think sometimes experience may create a hesitation or promote a therapy to one of our patients alone. So I think really being able to have the understanding, yes, a patient may have a side effect, doesn't mean 1,000 patients have the side effect all the time. So it's having that understanding and being able to read the literature and see the progression-free survival or the overall survival of each of these immunomodulators going forward, and even reaching out to other support systems. So even the Bristol Myers Squibb has a healthcare professional line that if they have questions to ask that they may not be able to reach their healthcare professionals in their institutions to discuss, having that support system and being, I really have a question, can somebody talk about it? And being able to freely talk one-on-one with somebody on the same level will help with change some of those bias that we see.
That's a really good point. I think just thinking about those, you've seen 5 people with this side effect, but there's another 50 people that you haven't seen that have not had them.
Everybody gets it.
Yeah.
That's the comment.
Right. What are some common misconceptions about immunomodulators?
I will say some people will still say there's no harm. When it comes to embryo-fetal toxicity, patients may say, well, nobody's ever gotten pregnant when I've used it, so it's fine. And I think those things have to be reinforced that it is part of the REMS program, but there is a lot of data that shows that it can cause fetal embryo toxicity when we see that. So really keeping those misconceptions when we talk about it. I did not think there's misconceptions of how the therapy works because they've been around, as we can say, since 1999 from thalidomide and has really changed since 2006, has become one of the forefronts of therapy in myeloma.
We've seen a lot of it.
Yes.
What's something about this topic that's not often discussed, but you wish people knew more about?
What do they need to know more about immunomodulators is that it is part of induction therapy and it's part of maintenance therapy in patients, whether they get an autologous stem cell transplant or defer an autologous stem cell transplant. So putting it in there that it is going to be part of a patient's journey in myeloma going forward. So I think reinforcing that going there.
That's a really good point too. You talked a little bit about some of the resources that people have, but what's some additional training or education that oncology nurses or other healthcare professionals need to stay current on this topic?
When we talk about, especially when the Oncology Nursing Society, right, ONS, has the educational biotherapies being certified on how to handle different chemotherapies, even including immunomodulators. So being abreast of that and keeping that certification valid. Also reading. I said, again, going to the International Myeloma Foundation or the Multiple Myeloma Research Foundation, the MMRF or the IMS, is really important because newer literature comes out, newer pamphlets that are available for either healthcare professionals or for the patient so that you're providing both requirements to each side. I love to read what patients actually are given to see how it's written and what it's explaining to the patient, because the patient's going to ask me the question about the document that's in front of me. And if I say I never read it, then it's not helpful for that. So I think it's having that, being part of different discussion boards, having these over discussions and saying, hey, have you seen this side effect before? How did you manage these different side effects on these particular therapies instead of trying to be the lone wolf and kind of digging through the weeds to figure it out through Dr. Google or the assistant, GP chat. So it's kind of really getting it to the right source.
What are some additional resources for patients and healthcare professionals who want to learn more about this?
Like I said before, IMS and the MMRF are extremely great resources out there. They also have many good hotlines, 800 numbers for all healthcare professionals, caregivers, and for the patients themselves to reach out. Both organizations also have support groups. They have active speakers like myself. We go and we speak to the patients on particular topics and allow them to be able to freely ask any question that they want on the therapy, specifically with the immunomodulators.
Do you have any final comments, Daniel? It's been great talking with you today.
My final comment is really talking in general with multiple myeloma. It is in the renaissance period at this point. We have really a lot of new therapies that are showing our patients having great progression-free survival and overall survival rate. Until the addingness of the immunomodulators, patients did not have a great overall survival rate. But then when we introduced, besides the thalidomide, but really introduced lenalidomide, we started seeing our patients have life expectancy between 5 and 7 years, which was unheard of at the time prior to these immunomodulators going forward. So it's very promising that patients are now being able to experience events that they thought they would never be able to see a newborn or a new grandchild come in, or see somebody go to graduation or go to a wedding that they were, or take a trip that they've always wanted to take and not be tied down because these are oral therapies and not have to go into a cancer institution twice a week for therapy. So I think it's a lot of promising, and it allows patients to have quality of life versus therapy of life.
I love that phrase. I agree with you so much, Daniel. Again, thank you so much for talking with me, and have a great rest of your day.
You too. Thank you so much for this opportunity.
Thank you for listening to the ONS podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org and ons.org/voice. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.